your interest. My name is Sanaz Halvaei. I'm one of the clinical and research fellows at Wessex Neurological Centre in Southampton General Hospital. And I'm one of the researchers and APS Regional Specialist Clinic at Wessex Neurological Centre. Today, I'm going to speak about one of the research projects we are doing at University Hospital Southampton. It's called UHS QOLAPS and is utilization of health services and quality of life of patients with atypical Parkinsonian syndromes. Sorry, I'm just trying to, okay, good. So this study was funded by PSPA Association. The sponsor of this study is University Hospital Southampton. The chief investigator of our study is Dr. Boyd Gosh, who is a consultant neurologist at University Hospital Southampton. And the co-investigators of the project are Dr. Luke Massey, Jade Donnelly, and myself. Just to start with my disclosures, as I mentioned, the research is funded by PSPA Association. However, PSPA Association, like the funder, has no role in the design of the study. They obviously assessed the study and agreed to our research and agreed to fund the project in terms of their own preferences and priorities. The sponsor of the study is University Hospital Southampton, which also provides some funding for the resources that we need to conduct the research, and is also responsible for overseeing the proper conduct of the research according to good clinical practice. I am an employee of University Hospital Southampton as a researcher, and basically my conducting this research is one of my job responsibilities in this role. Okay, just to briefly mention what we want to achieve in this session, what we want to talk about. First of all, as I mentioned, is introducing the research project UHS QOLAPS. We want to basically we want to explain more about what we are doing this research and what we want to achieve by doing this research, what is the importance, and what are the potential benefits for people with APS who are suffering now or people in future who might get APS. Basically, an explanation of the importance of our research. And we also provide some information about how we recruit our participants and how participation in our research, what participation in our research involves, what would we expect from our participants. And then we provide you some opportunity to ask your questions and also facilitating your recruitment to our project today. Okay, I just want to go very briefly to some facts about APS. Just as you might all know, APS is a general term. Atypical Parkinsonian Syndrome, or APS, is a general term for PSP, CBS, MSA. You might already know that these conditions are very rare. There are like 4 to 6 people in 100,000 people. Is the prevalence of the of APS. The fact that these diseases are very rare is kind of might have cause some problems for you. For example, clinicians, like even doctors, even your GP, or if you go to a hospital in A&E, clinicians might not know much about your condition, unfortunately, because they do not see these kind of patients very much. And for example, you might have some experience going to A&E, and maybe people looking after you, even doctors or nurses, they might not fully aware of your condition. This is one of the problems of people who with APS who attend like A&E or like any center which is not a neurological center. And as you might know better than me, there is a neurological condition which is progressive. The progression is quite fast, and it severely affects the quality of life of people who have this condition, and also their carers. Okay, so just starting showing you some facts about the disease, just very briefly. As I mentioned, I understand you might already know lots of these facts, but I just want to give a background to be able to explain more about my research. So this is a graph about the quality of life of people with different neurological conditions. So basically, if you look towards the right of the graph is a good quality of life, and toward the left is a bad quality of life. And as you might see, PSP is one of the conditions which has basically the worst quality of life in all these diseases shown in this graph. And some of these diseases, they are also neurological and progressive disease, like motor neuron disease or Huntington disease. These diseases are also progressive debilitating neurological disorders, but we still can see that people with these conditions, even then they have better quality of life of people with PSP. So that's basically the importance. We want to look into the problem and find out why the quality of life of people with PSP are much worse than lots of other neurological conditions. The other fact about PSP is that PSP and CBS is that it doesn't only affect the person with PSP CBS. Also, quality of life of carers are very much affected. So there's been some research about the quality of life of carers as well, and the data that's been gathered in this research is that, first of all, 80%, like most patients with these diseases, are being looked after by the spouse, and basically carers spend almost all of their time looking after their husband and wife, and also the carer burden, like for example, depression in carers of these people was worse than people who are looking after other conditions like Parkinson's disease. And again, also quality of life of care of these patients, like of APS patients, are worse than carers of other neurological conditions like Parkinson's disease. And also in these two graphs, what I wanted to emphasize putting these graphs in the slide is the quality of life of carer is so much relevant to the quality of life of patient. And as you see in the graph, as the disease worsens and as the quality of life of patient worsens, the quality of life of carer also worsens. So basically, if we can find a way to improve the quality of life of the person with APS, we perhaps would be able to also help with the quality of life of their carers in some aspects. Speaking about costs, so it's not only quality of life that is affected. We also think that speaking of cost is also important in APS, because if you want to establish a reason for NHS to do something about this problem, we only need to show them the pretty much expensive costs that should be expended on people with APS. As is shown in graph, people with PSP has had the highest economic cost. This is a research was done in 2011, and it shows that basically PSP has one of the highest economic costs for the NHS. And it is estimated that PSP alone costs like about £195 million annually for NHS, which is a huge amount of money. And it's also estimated that 40% of this cost is for inpatient costs. So what is the problem? Why, despite of all these costs, still the quality of life of patients with PSP is still very poor? And is there any way that we can improve the situation? Well, our answer is yes, despite the fact that PSP and CBS are progressive diseases in nature, and we don't want to deny that. But we think that there is still lots of actions we can do and lots of room for improvements, which can be done to help these patients and their carers to have a better quality of life, to improve their quality of life. And that's why we are doing this research. So I just want to give you a little bit of background information so that I can explain our research more clearly to you. I'm not sure if you have ever, if you have heard about NICE. NICE is an organization. NICE stands for National Institute for Health and Care Excellence. Is a public institution in England that develop evidence-based recommendations for healthcare practice. Basically, their job is use the high quality research that have been done in certain diseases and provide some guidelines, some recommendations for different health organizations, including NHS, to how to deal with, how to care for one specific disease. For example, if NICE wants to provide some guidelines about diabetes, they would go to all the research that has been done in that area, and they provide some guidelines that help the NHS organizations to know what to do, what is the best care for people with diabetes. Some of the NICE guidelines are statutory, which means that healthcare providers or NHS are legally required to consider those guidelines when planning for services, for the delivery of health services for patients. So basically, it's just like basically NHS organization would be obliged to provide those recommendations mentioned in the NICE statutory guidelines. And these statutory guidelines are mostly for improving health outcomes, for standardization of care, which means having an equity of care, like all the people have receiving the care they need, regardless of their location, regardless of their background or any condition. So, and also cost effectiveness. As I mentioned in my previous slides, there is high costs in PSP, low quality of life. So it might mention some problem that maybe the services we provide is not very cost effective. So basically, these are the thing that is the objective of NICE statutory guidelines. But unfortunately, there is no statutory NICE guidelines for APS, which means that NHS organizations are not obliged by law to provide, to kind of implement the suggestions, implement the current best practice guidelines for people with APS. And the reason that there is no statutory NICE guidelines for APS is that currently there is very little evidence, very little research which has been done about the efficiency of health services, the benefits of health services, the cost efficiency, and the outcomes. So you as patients, you might receive different type of services, but basically no one has ever really studied through a good quality, like a high quality research, what has been the outcome of these services. That's why basically organizations like NICE cannot provide any statutory guidelines in this area. There are some best practice guidelines provided by different advisory groups, obviously different neurological experts, but as I mentioned, as they are not a statutory guideline, so in different NHS organizations, depending on how much funding they have, depending on their own priorities, they can choose to provide or not to provide these recommendations. So this is the problem that we face in APS. If I want to give you an example, If you have a look at this image, it shows all the different health professionals, like different health services that a person with PSP or CBD needs as part of their care. You might already be receiving some of them. Some of you might receive more, some of you might receive less. Yeah, it's basically depending on your location, you might receive some of these services either in community or in the clinics you attend. Unfortunately, this doesn't happen in the whole country. If I want to give you an example of a similar disease, for example, motor neuron disease, as I mentioned, is also a neurological disorder, which is rapidly progressive. But because there has been lots of research which has been done in motor neuron disease, so all these research have provided enough evidence for organizations like NICE to provide these statutory guidelines for NHS organizations. For example, one of the research has been done in motor neuron disease has recommended that the addition of a specialist MD multidisciplinary clinics has resulted in improvement in quality of life of patients with motor neuron disease and lots of different functions and aspects of their illness. So because there has been this research available, so the guidelines was created and the different NHS organizations are required to provide multidisciplinary clinic in lots of different locations in a fair distance of every patient with motor neuron disease. So basically every patient with motor neuron disease, regardless of their location, they might have the opportunity to attend a specialist multidisciplinary clinic. Similarly, there has been some similar research in Parkinson's disease, which also led to creation of statutory guidelines. But as I mentioned, in APS, there are expert opinion recommendations. There are some research, but unfortunately, they are not enough. They are not providing a solid evidence of the cost efficiency and the benefits of different services. And that's why there is no statutory guidelines. And if you think of NHS organizations, they're struggling with money. They have limited amounts of funds. And obviously PSP and CBS are very rare diseases. So they have lots of other priorities, lots of other diseases that are much more common, and also lack of evidence. If you imagine if as a balanced scale, there's a lack of fund, rare disease, lack of evidence. So all of these kind of push back the NHS organization to put more funding into creating specialist clinics for patients in different locations. So that's why we are doing this research to address this very big problem. Another aspect is clinical coordination. A clinical coordinator is a healthcare professional who provides a point of contact in between your appointments. So you might not have very regular appointments with a neurology consultant for APS, maybe every 6 months or so. But during the 6 months, you might have lots of problems coming on that you might not have any contact to ask, and even your GP might not be able to provide you to address your problem as needed to be addressed. So a clinical coordinator is a point of contact between you and your neurology consultant to facilitate your problems, to facilitate your kind of requirements, your needs, address your problems during in between your appointments. And again, similarly, in motor neuron disease, there has been lots of research which showed the beneficence of a clinical coordinator for motor neuron disease patients, which has actually led to increased survival slower deterioration and decreased hospital admissions. And that's why having a clinical coordinator in motor neuron disease clinics is much more common than APS, which is again because of more research that has been done in motor neuron disease and less in APS. This chart shows you a report of one of the service evaluations we have done in our regional APS clinic. So basically, if you have a look at the blue bar, this is the quality of life of our patients in 2017. And then in 2018, we added a clinical coordinator to our APS clinic at Southampton General Hospital. And as you see, the quality of life has significantly improved a year after adding a clinical coordinator. This project is being done as a service evaluation. It's not being done as a research. So that's why we can't use this as evidence for pushing NHS to provide more clinical coordinators. But hopefully in this research that I'm going to introduce, one of the aspects we are looking at is having a clinical coordination in all APS clinics around the country. So some of you might ask, why do you need to do research about this? Obviously, if there is more support for patients for any type of disease, patients' outcome gonna improve. So why do we need to do our research? And also, there's been solid evidence in other similar diseases that all these, like having a specialist clinic will help, having a clinical coordinator will help. So why do we need to do all this research? The answer also goes back to the NICE guidelines I mentioned, because we cannot kind of create guidelines based on only recommendations or based on similar results in other diseases. So that's why we need to do similar research in APS to be able to persuade organization to create guidelines, to persuade our NHS trust to support having more specialist clinics. And hopefully in our research, what we want to do is to build a solid evidence that having a specialist clinic will help, having a clinical coordinator, having multidisciplinary team will help the quality of life of our patients, and is cost effective, because also having a multidisciplinary clinic, having a specialist clinic is also expensive. So in this research, we want to prove the cost efficiency so that we can persuade the NHS trust to provide more of specialist clinics in the whole country, not only in big cities. So regardless of where the patient lives, they have access to an APS specialist clinic with a multidisciplinary team involved in their community care. So in a nutshell, our research would be the first and the most important step in providing this evidence. And hopefully after we release our data, other centers, other big centers will also persuade that we also gonna encourage to do even further research. So the evidence we have is just gonna grow and grow. Yeah, that's basically why we want to do this research, and that is the importance of our research. So if I want to say in a nutshell of the aim of our UHS QOLAPS project is investigating the effects of different models of clinical care in patients and their carers. As I mentioned, people with APS right now are receiving different services. Like some of you might be seen in APS specialist clinic with lots of people like physiotherapists, occupational therapists, speech and language therapists involved in your care. Some of you might see less of these specialists. Some of you might just be seen in by a neurologist alone. which are also like all of them might be doing a great job. But what we want to do is studying the effects of all these services our patient or participant will receive, the outcomes, and finding out the model, the health model, and the health model with the best outcome. And also we want to investigate the involvement of different health practitioners and how this involvement affect patients and their carers' quality of life, and also other outcomes of disease like number of hospital admissions, the amount of health utilization, and other aspects of disease outcome. What we have done until now, we are actually doing this project for a couple of years at Universal Hospital Southampton in our APS regional clinic. We already have 90 participants recruited to our research. They're all from our clinic. But right now we want to expand our recruitment to study about the outcome of services other patients in other areas and other regions receive. So that's why we want to expand our recruitment to people who are not attending our clinic at the moment. Obviously, recruitment from our clinic still continues. So if you are attending our clinic and if you are not already on QOLAPS, you can consider taking part. But even if you are not in Southampton or the area covered by Southampton, and if you're not attending our clinic, we are really interested to recruit people from outside of our areas because of the reasons I mentioned. And we have facilitated recruitment from patients who are currently living in residential homes. Basically, patients who are in nursing homes, in care homes, they are severely underrepresented in research. And that's mainly because they might not have enough support, for example, from family members to help them participate in the research. And it's very important to also involve people who are currently in nursing home, care homes. And that's why we have facilitated their recruitment as well. And hopefully we're gonna recruit a good number of people from residential homes as well, so that we can study their outcome of illness as well. So how we recruit people, I just want to explain about our recruitment and also your participation in research. So just to help you to maybe decide if you want to participate or no. So basically, if you feel that you are interested either in participation or if you just want to hear more about our research, you only need to provide your contact details to either PSPA Association or to our email address or phone number, which I provide later directly, just basically a mean of contact, so I can contact you later. And after this, we will contact you and we provide more information. We will, there's some eligibility criteria which are not very rigid, but we still need to check that you are suitable for participation. And after everything was okay, we will send a patient information sheet and informed consent forms to your home address by post. So you will have enough information. You will have the information at your home to go through at your own time, speak to your family members, just take enough time to decide if you want to participate. And if you felt that you were interested, we will contact you again with a phone call. And if you have more questions, if you want to go through any other issues, we can discuss it together. And we can fill in the consent form through a phone call. And the consent form will be sent back to us by post again. So you don't need to basically attend any extra appointments because of participating in research. And also, I just want to emphasize that a research is a questionnaire-based research and mainly data information gathering. It doesn't involve any giving you any medication or any extra intervention. And that's why, again, you do not need to attend any extra, like hospital or any other appointments apart from your normal care. So it's only by posting back questionnaires. So about the questionnaires, after we receive your consent forms, we will send you questionnaires by post again. Questionnaires are every 6 months, and we fill the questionnaires with your carers. There are some questionnaires for your carers as well, which you just fill in the questionnaires together and post them back to us. Obviously, there should be some neurological assessments in between, just to have an eye on the progression of your illness. For our patients in our clinic, these assessments, these basically ratings, are just part of their normal clinic examinations. So every time they attend our clinic, we do some physical examinations, and we just use the data in the research. But for people who are not attending our clinic, obviously we need this information, and we understand the difficulty for you to come to Southampton. So we do some neurological assessment as a home visit, which is only twice during your participations, once in the beginning and once a year later, but it's all done in a home visit. After you give us consent, we gather some information from NHS hospitals that you might have attended, from your GP, basically asking any admissions you have, any health services you used, and some background information, medical information about your illness and yourself. And we also gather some information from Office of National Statistics. As any other research, your participation is totally voluntary. It's totally up to you if you want to take part or not. There is no pressure. You're just considering your own personal situation. We understand that you might already have lots going on, and doing a research would not be very convenient for you and your carer. So there's no pressure at all. But also, if you decide to participate, you also have the right to change your mind in the middle. If, for example, 1 year later or even a few months later, you felt that it's so much filling the questionnaire and you have so much going on and you cannot do the research anymore, that is absolutely fine. The only thing you need to do is just informing us, and we will withdraw you from our study. We will only use the information we gathered up to that point, but we wouldn't send you any questionnaires again, and we wouldn't use any information again. And also your participation and your information would be strictly confidential. This was a very brief introduction of our